Well, thank you everyone for allowing us to present our work at the association here this morning. So microsurgical reconstruction of lower extremity defects remains challenging for those of us who undertake these cases, and flap loss rates in lower extremity trauma reconstruction is higher than other anatomic areas for microsurgical reconstruction. Traditionally, muscle flaps have been used, secondary to their belief that they are better at filling dead space, promoting bone union, and also reducing the risk of infection. Recently, with the rise of fasciocutaneous perforator flaps, the trend has been towards more use of these flaps for lower extremity trauma patients. As they avoid muscle sacrifice, they have an ease of elevation to allow for secondary orthopedic revision, and also in many of our hands have a superior aesthetic result. In this age of data-driven and patient outcomes, we need really a better guide to choose our flap selection in these lower extremity trauma patients. So the purpose of this study really was to compare the reconstructive and functional outcomes of muscle versus fasciocutaneous flaps in our lower extremity trauma population, and importantly assess the rate of secondary procedures that are common to these patients, such as flap revision, flap elevation for orthopedic secondary procedures, and the need for secondary skin grafting as well. This was an IRB-approved multi-institutional database from Duke University and the University of Pennsylvania. Query of this database yielded 518 muscle and fasciocutaneous free flaps for lower extremity reconstruction for traumatic injuries. About 2/3 of the patients were from Duke University and 1/3 of the patients came from the University of Pennsylvania. It yielded a follow-up of about 4 years with a large range to 9 years. Importantly, we looked at the outcomes for muscle versus fasciocutaneous free flaps, and we looked at several points, including flap thrombosis, salvage, flap failure, limb salvage, and ultimate need for amputation and time to ambulation, and the need for secondary procedures such as flap revision or flap elevation to allow for orthopedic revision. We divided the patients into 2 subgroups, the first being acute, which we defined as less than 30 days from their initial trauma, secondary to the need for referrals into our institution, and also patients that are on the trauma service being stabilized before they're suitable patients to undergo reconstruction. The second group being those lower extremity trauma patients that had the sequelae of chronic from previous orthopedic trauma, such as osteomyelitic patients or chronic non-union patients. When we look at the free flap distribution between both groups, between the acute trauma and chronic traumatic patients and our use of muscle and fasciocutaneous flaps, muscle flaps had a significant more use in both of these populations. And if we look at the trend of muscle flaps, it trended towards what one would expect, latissimus flaps and gracilis flaps on the muscle flap side, and on the fasciocutaneous flap side, we tended to use anterolateral thigh radial forearm flaps. Duke University tended towards muscle flaps, and University of Pennsylvania trended towards fasciocutaneous perforator flaps. Not surprisingly, if we look at the trends over time and the use of muscle versus fasciocutaneous flaps for both of these groups, fasciocutaneous flaps certainly were on the rise, while muscle flaps were on the decline, which reached statistical significance in both groups of patients. And this is in no doubt because of this flap, which is the anterolateral thigh flap, which remains our preferred flap for lower extremity trauma reconstruction due to its versatility, its very advantageous donor site, and the ability to harvest while the patient is supine. And our group has previously reported on the versatility and use of this flap in the orthopedic trauma population. If you look at the patient characteristics, not surprisingly, there's no demographic data that stood out as statistically significant. The 2 factors that trended towards significance were being male and being a young male that ended up landing you in the trauma bay with an orthopedic injury. If you look at the defect characteristics of these patient populations that trended towards significance, it was defect location with latissimus flaps or muscle flaps typically being used for defects from the knee to the ankle, with a preponderance of fasciocutaneous flaps being used for foot and ankle defects. If patients had a Gustave 3B injury or exposed hardware in the acute trauma setting, muscle flaps tended to be used, which also reached statistical significance. The operative factors that played out in these patient populations, muscle flaps were a larger surface area. Not surprisingly, they needed more skin grafts. The operative time was longer for the fasciocutaneous group. This is likely secondary to our learning curve for perforator flaps in the early days of us transitioning to perforator flap reconstruction. If you look at the outcomes, and this really is probably the important slide, and if you look at our endpoints such as flap thrombosis, flap failure, limb salvage, and need for amputation, the groups were equivalent. Both muscle and fasciocutaneous flaps yielded similar numbers in both the acute trauma patients and both in the chronic traumatic sequelae patients, rendering the outcomes equivalent. If we look at their functional outcome and return to ambulation, both muscle and fasciocutaneous flaps, looking at the Kaplan-Meier curves for return to ambulation, were both similar. When we plugged the variables into Cox multi-regression analysis, the one factor that teased out was the presence of orthopedic hardware that delayed their return to ambulation, which is not surprising as many of these patients have a concomitant orthopedic injury which delays their return to ambulation more so than their soft tissue coverage needs. A lot of these patients will require secondary procedures. There was no difference in number of flap revision or number of flap revisions between muscle or fasciocutaneous flaps. If you did have a fasciocutaneous flap, however, you were more likely to have this flap elevated to allow for a secondary orthopedic procedure. But this is likely a result of selection bias and picking a fasciocutaneous flap for those patients that we anticipate will need secondary orthopedic revisions. So this is our typical algorithm for lower extremity trauma reconstruction at the University of Pennsylvania. This is a patient with a typical soft tissue defect overlying the medial lower extremity with an intercalary tibial bone loss with an antibiotic spacer, covered with an anterolateral thigh perforator flap, then to allow soft tissue healing and delayed bone grafting at 6 weeks after their initial flap reconstruction. So really what is the answer? Is one better than the other? Is fasciocutaneous flap better than muscle flap for these patients? And I think the important answer is they're really equivalent. There really is no better flap than one over the other. So they're both equivalent outcomes. They both achieve similar rates of limb salvage and recovery. Fasciocutaneous flaps did enable re-elevation of the flap for secondary orthopedic procedures on a much easier time. And over time, we've had increasing preference for the use of fasciocutaneous perforator flaps for our lower extremity trauma population. And I'd like to thank these additional people, and thank you very much for allowing us to present here today.
Thank you for that presentation. The discussant will be Scott Hansen.
Steve, thank you for that excellent presentation. I think that, for those of us that do a lot of lower extremity reconstruction, this is a topic, like a daily topic, and a lot of us who have trended towards perforator flaps over the years have always trying to back up the use of perforator flaps as opposed to muscle flaps. I have 3 questions for you. So how do you decide when to use what flap? Did you analyze the morbidity of your donor sites? Because I think that's one of the topics that we oftentimes talk about in using a perforator flap. And then lastly, and more importantly, are the union rates similar for fractures in the 2 groups?
Yeah, the last question is probably one of the most important questions. So the question of union underneath a muscle flap or a free fasciocutaneous flap is a hard one to discern, and actually it's an ongoing project for us through this database trying to answer that question. My take on it is that the union rates are in fact similar, but it is an active area investigation, but my take on it is that they are similar. In terms of flap selection, I think with our facility for perforator flaps, particularly the anterolateral thigh flap, if the patient has a reasonable BMI, we tend towards perforator flaps. And it's just the ease of the harvest. They're supine. You don't have to turn the patient in the operating room. It's a very favorable donor site. Most of the time you can close even large donor sites primarily. I think the morbidity of the anterolateral thigh flap or other perforator flaps is the inability to achieve skin-to-skin closure of the donor site, which means they end up with a secondary skin graft down the road, which from a functional standpoint is not a big deal, but from a cosmetic standpoint can be somewhat less than ideal for these patients. And they may need some secondary revisions down the road for their donor site.
Steve, what will be your preferred choice for reconstructions for foot involving the glabrous skin?
So for weight-bearing surface of the foot, when I first started in practice, I did all muscle flaps because that was sort of the mantra that you had to use muscle for foot. And then as we started using perforator flaps for most defects, we started using perforator flaps. Perforator flaps on the weight-bearing surface of the foot, though, as they start to weight bear, there's much more of a shear plane, even if you take the fascial backing off of the flap, and they end up with pseudo bursa underneath the flap that you end up having to go back a high percentage of the time and revise. So for weight-bearing surface on the foot for glabrous skin, I've actually gone back to muscle flaps just because it kind of scars in and socks down and doesn't really have that shear surface underneath the flap.
Yes, Charles Dupin from New Orleans. I have a question and a comment. I wonder a little bit about selection bias in this study. And You pointed out in your earlier description that for things like exposed hardware or gunshot wounds, high-velocity injuries, there's a bias toward using muscle flaps. Were you able to break this out to see how well the fascicutaneous flaps did in these very high injury, large amount of soft tissue trauma cases or not? Because if there is a selection bias, then maybe we should be using the muscle flaps for these horrible cases. And in New Orleans, we see a lot of high-velocity gunshot wounds of the lower extremity, so we see these disaster cases. The second thing is one advantage that wasn't espoused with the use of latissimus flaps, the ability to transfer the lateral bar to the scapula based on the angular artery. So if you have a patient with a large butterfly segment, for example, which is moved, you can in one stage do a free latissimus and bone reconstruction, which may make the difficulty with doing a second procedure not very relevant. But thank you. This is wonderful. Thank you very much. It's a large series, very large series, and I think it's interesting to know that absent selection bias, that both these flaps tend to work well.
Yeah, thank you. I think what's probably more important than the flap that you actually put on the defect is adequate debridement and getting back to some reasonable healthy tissue in the wound bed, and making sure whatever flap you harvest actually is perfused in its entirety. And you can harvest an enormous anterolateral thigh flap and sometimes have some marginal areas in the corners that don't perfuse very well. But the same is true of a latissimus flap. And that very distal end of the latissimus flap that you always want to cover that last little bit that ends up not doing so well afterwards as well. So I think it's probably not so important as the flap you use. They're going to have equivalent outcomes, but really wound preparation and getting the wound bed ready to accept the flap, and whatever flap you put on it is perfused in its entirety. I think the need for secondary bone grafting and secondary revisions in these patients is not insignificant. I think if you have an intercalary segment and you can do this in one stage with a piece of scapula and concomitant latissimus flap, I think it's terrific. That hasn't traditionally been our experience. A lot of these patients, we've gone back and resurfaced their lower extremity with a perforator flap, and then gone back secondarily and either did mascule once we removed their spacer, or even gone back if it's a larger intercalary defect and done a free vascularized bone graft and put the patients in a talar spatial frame for their bony union.
Steve, great paper. Can you tell me what percentage of your perforator flaps were composite? For example, do you ever take a cuff of vastus to cover a plate? And if so, when do you use that?
So I typically take no muscle with them. They're all strictly perforator flaps. So I think, especially for lower extremity, knee and below, sometimes if you take a piece of muscle, it's very hard to inset the flap and get skin-to-skin coverage, which is really what I want for a lot of these patients. So you have a big bulky piece of muscle or even not so bulky piece of muscle, and you can close almost 3 sides, and then that last side it's really hard to kind of close to the surrounding skin to get skin-to-skin coverage. So these are all perforator flaps, no muscle. I think the instance where you'd want muscle is, potentially if you do have some dead space or if you want to cover the orthopedic hardware with some additional muscle. But I think, sometimes when you harvest that little piece of vastus with the overlying skin island, it's, in many ways a non-anatomic dissection or just kind of boving or cutting this piece of muscle with a perforator running through it. And sometimes the edges don't look very well perfused, and I'm always a little worried about the perfusion of that muscle segment or leaving something that's devitalized behind. So they're just strictly all perforator flaps.
Thank you very much for that. Our next presentation is the world's first pediatric bilateral hand transplant, ethical considerations and implications by Benjamin Chang.
Thank you for the opportunity to present this work from the University of Pennsylvania. Almost 2 years ago, the first bilateral pediatric hand transplant was performed at the Children's Hospital of Philadelphia, and today it's our privilege to present to you some of the key social and ethical issues regarding pediatric hand transplant. While ethics and morals relate to both right and wrong, ethics is governed by rules external to the individual, whereas morals are an individual's own principles regarding right and wrong. The 6 principles that you see here of medical ethics, we'll focus on the first 3. The first being non-maleficence, and non-maleficence can't be strictly applied to surgery. With any surgical treatment, it is ethical to inflict surgical trauma if the benefit outweighs the risk. In this case, efforts were made to minimize risk and maximize chances for success. Moving forward to informed consent and adequate mental capacity for autonomy were also very important since this is a pediatric patient. In this case, since it's a pediatric patient, the informed consent was from the parents. However, the patient himself was given the opportunity to assent to the procedure and understand it at a very basic level. Even the first transplant had ethical considerations to it. In 1954, Dr. Murray performed the first kidney transplant on identical twins. So while rejection was not necessarily an issue, potential harm to the donor was. If we look at a brief history of hand transplant, we see in 1964 was the first hand transplant, which was rejected after 2 weeks, which shows us some of the common pitfalls of hand transplant. In this case, being lack of immunosuppression and understanding at a basic science level. In 1998, another transplant was performed, and in this case it was removed in 2001, secondary to the patient's request, after multiple bouts of rejection, and this was secondary to non-adherence to medication compliance. In this case, the pitfall being lack of screening and selection process. The first long-term, and is still surviving, is the transplant that was done 17 years ago at the Kleiner Institute by Dr. Breedenbach and his team. They, in contrast to the previous studies that I mentioned, had performed several years of basic science research and feasibility studies in order to ensure success. So the team at Penn actually visited the Kleiner Institute, and subsequent to that, in 2009, developed the Penn VCA hand program. And 2 years later, performed a bilateral hand transplant on 28-year-old Lindsay S. Over 2 years later, she's been doing very well. She functions independently and lives independently as well. 2 years later, after Lindsay, a 6-year-old boy presented to the Shriners Hospital in Philadelphia for a new hand prosthesis. And he was unhappy with his current prosthesis, and he felt, quote, that they do not feel like hands. And this patient actually felt like he could function better without the prosthesis. Zion Harvey, he was healthy until the age of 2, when he had staphylococcal sepsis, resulting in renal failure and quadrimembranal amputation. At age 4, he received a renal transplant from his mother. He was doing well with lower extremity prosthesis, as you see depicted here, and he was ambulating without assistance. However, with the hands, it was a bit of a different story. He had failed hand prosthesis, and despite his best efforts to use them, again, felt that he was better off without them. So when the team had first met Zion, they had some serious reservations regarding pediatric VCA in general, and these include the risk of immunosuppression, the fact that pediatric patients adapt well to amputation, the consent process being a minor, the rehabilitation and compliance that goes along with postoperative regimen, and the fact that we're dealing with smaller parts. It's a technically more difficult surgery, anatomically speaking, and the lack of donors for future considerations. The transplant team, as you can see, is multi-variables and many teams here. The first stop, however, was the bioethics department, and this whole course took place over a span of 18 months and multiple clinic visits. From our discussions with the bioethics, we were able to derive 6 main issues, as you see listed here, and we'll entertain each of them individually. The first is patient autonomy, which is involved in parental consent and patient assent. The ability of the patient to assent may be limited upon these factors, intellectual and emotional maturity. So Zion needed to demonstrate understanding of the procedure at a very basic level and be able to assent if he wanted to. So a number of dialogues took place where the patient would ask where his hands would come from, and he was reassured that no one had to die specifically for him to get hands. The mother at one point had asked, what happened if the hands didn't work? And the patient himself was quoted reassuring his mother, saying, if it gets messed up, I don't care because I have my family. He demonstrated maturity beyond his years. Further, compliance with his therapy and medications was reassured with discussions with his nephrologist and therapist in Baltimore. Not to be overshadowed by intellectual emotional maturity is the impact on personal identity that the hands have. In fact, multiple studies have shown that appearance improvement is associated with improvement in self-esteem, psychological functioning, and similar factors. The risks that you see listed here were carefully weighed against an improvement for quality of life in this patient. The first risk, the need for lifelong immunosuppression, is mitigated by the fact that Zion had already had renal transplant, and some of the risks included there were that he may need higher doses that could contribute to toxicity. To mitigate the risk of loss, we held multiple rehearsals in the operating room and spoke with a number of experts in this field regarding rejection. Non-compliance has been a major issue regarding immunosuppression. According to this recent review by Dr. Lee, only 5 hand allografts in the US and Europe have been lost in the non-acute period, and 4 of these 5 may be attributable to non-adherence with the medication regimen. For the pediatric patient, and of course Zion had already demonstrated this ability to comply, for the pediatric patient, family support becomes paramount. Zion lived with his mother. His mother was his primary caregiver and also the donor of his kidney. She had demonstrated an active, vested interest in his well-being, as well as the rest of his extended family, and his proximity to the institution at CHOP also helped. Did that go black? I don't know what happened there. Okay, we'll continue on. So, in addition, some of the concerns as well, either way, it's not a problem. So, Dr. Webster had put out recent literature years back regarding some of the unknown factors in immunosuppression and risk of malignancy. And we talked about some of the known factors here just a second ago, but how about some of the unknowns? The risk of malignancy in VCA. And so, as you see depicted in this graph, the risk of malignancy grows after renal transplantation in patients under 35 years of age. Zion certainly fits into this category, but what about his status as a pediatric patient? What about a VCA on top of solid organ transplant? Does that increase the risk? And of course, the risk of long-term function as well. As you see, favorable selection factors of this patient made him an excellent candidate for this procedure. As we saw from our study, though, there were critical issues that contributed to considering this patient or any patient for a pediatric VCA, and those include psychosocial, compliance, and family support. This is not a feasibility study. This is a therapeutic study that was done primarily for this patient and not necessarily for research purposes. This is a proof of concept, essentially. What is needed going forward is directed to be generalizable knowledge. And so in future patients, we will obtain pre- and post-op imaging, non-invasive MRI, essentially, functional MRI, and magnetoencephalography to obtain cortical mapping. In fact, Zion has undergone post-operative imaging in 3 to 4 month intervals and has shown dramatic increase actually in cortical somatosensory improvements in the brain. We also need to develop age-appropriate outcomes measures so that results can be tracked and monitored. Thank you.
Let's discuss and release Dr. Moran.
This is really historic, and I think your group and your team need to be congratulated for such a thoughtful approach to this. And really, it's critical if we think back to the first hand transplant on the patient from Lyon. I think the fact that that patient stopped taking their immunosuppressive medications really set the field back. And I think from a public perception, it's also very important. Many of us who take care of kids have a population with meningococcemia that are all quadrimembranal amputees. And so this procedure really provides a tremendous amount of hope for those patients. But there are a lot of questions that still remain. And my first question for you is, with regards to the parent's education, when you transplant a patient, you subject them to a large dose of antigens from the donor arm. It's going to be very difficult for Zion to obtain a second kidney. The average lifespan of the kidney is 12 years. We know that the lifespan of the arm may be 20. How did you handle that issue with the parents?
Mm-hmm. Well, through discussion with Dr. Chang, we were able to find out that we actually don't know what the future is going to hold for the VCA on top of the solid organ transplant. So, constant monitoring and making sure that the patient was on his immunosuppression and compliant with it certainly aids in that regard. But the truth of the matter is, it's at this point unknown what the long-term ramifications are going to be of that.
But the parents who are aware that a second renal transplant may be very difficult.
Right. To my knowledge, that was communicated.
My last question is, also obviously function is critical in this patient. We know that the transfer of growth plates and transplants in kids, even replants, the growth plate is very sensitive to ischemia. Mm-hmm. How have Zion's growth plates been doing as you followed him long term?
So his physes remain open. In fact, over the past year, his limb has grown 1 centimeter. So we know that they're still open, and they appear to be, as you saw in that video of him throwing the baseball, they appear to be growing in relation with the rest of his body.
Brian Gasper from Cleveland. Being on call 24/7 for the last year for a face transplant that hasn't happened yet, we were experiencing some issues. I'm curious what you did for this transplant. It's such a young patient. Did you restrict, or you must have restricted, what age restriction did you use for your donor, and did you require that your donor be transferred to your institution for the harvest, or were you willing, or did you actually go outward? And if you did, how far did you go to get your donor tissue?
Well, the donor was substantially younger than the recipient. And at this point, the hands appear to be growing quite well. To be honest with you, I'm not sure of whether or not the donor was actually at the institution or not at the time. In terms of taking care of the donor, prosthesis was made for the donor, so that way there was some palliation for them at that point.
I can answer some of those questions. Ben, do you want to? So because of the scarcity of pediatric transplant or pediatric donors, we expanded the geographic catchment area for the pediatric donor. So the donor was not local. We flew to procure the pediatric hands.
How long was your ischemia time?
It was probably, the cold ischemia time was probably on the order of about 2 hours, I believe, maybe a little longer, 2 to 3 hours cold ischemia time.
Really?
And then in terms of donor, we had essentially models made based on varying sizes of what would be an acceptable donor for Zion. So we actually had models with us to compare to the donor based on a certain percentage of size of what would be acceptable for transplanting.
So we talked to the group in France and in Boston, and their longest trip that they took was a 2-hour flight, and so that's what we're talking about now. So it sounds like you were willing to accept that kind of scheme time, and you used UW solution and slush, and that was, I mean, pretty basic organ transplant protocol, nothing special.
Yeah, standard UW solution on ice slurry, irrigate with ice cold UW, and then in a big cooler and
That's
get
what,
on
yeah,
get
so
on
it
a
seems
plane.
like everyone's doing. All right. Great, thank you.
Thank you.
Thank you.
Our next presentation will be outcomes of corticosteroid treatment of trigger finger by stage.
All right, I'd like to start by just thanking the association for this wonderful opportunity to present our research. I'll be talking about the outcomes of corticosteroid treatment of trigger finger, as I said, by stage. We have no financial or other conflicts of interest to report. Trigger finger has an incidence of 2 to 3% in the general population. Steroid injection is common practice for initial management. Common treatment paradigm consists of 1 or multiple steroid injections followed by surgical release if injections fail. Anecdotally, though, it seems that some patients fare much better with steroid injection. So the response rate seems to vary pretty widely, and that's supported by the literature where efficacy ranges from 47 to 87% with a single injection. Steroid efficacy, however, in relation to disease stage and/or comorbidities has yet to be determined, and this This paucity of data in this, with regards to these two variables was noted in the recent Cochrane review in 2009. So our study was aimed to help address this issue. We actually had two aims of our study. One was to determine the difference in response rate to corticosteroid injection based on trigger finger stage, and then determine if underlying comorbidities affected efficacy of steroid injection. We hope to use this information to kind of help determine if there's a subset of the population that may benefit from surgery as opposed to one or a series of steroid injections. The staging system that we utilized is one that's commonly cited and used in literature, the Quinnell staging system. We did clarify the stages with very slight modification just to improve precision and maximize inter-rater reliability. It's a 5-stage system. Stage 0 consisting of pain and tenderness over the A1 pulley. There's no clicking, popping, or locking. Stage 1 is pain with clicking, popping, or a palpal nodule, but no locking. Stage 2 is locking overcome with the affected hand. Stage 3 is locking overcome with the opposite hand. And Stage 4 is an inability to flex or extend the affected digit. This was an IRB-approved prospective longitudinal study that was conducted on consecutive patients at a single institution. The inclusion and exclusion criteria are listed there for you to see. We included stage 1 through 4 disease. Stage 0 was considered a pre-disease state and was treated with NSAIDs and/or splinting as opposed to steroid injection. We did exclude patients that had previous injection or surgery on the affected digit, and we also excluded poorly controlled diabetics due to concern that we'd increase their blood sugars to an unsafe level. Baseline characteristics were noted for every patient that entered the study. These are listed here. Obviously, we are particularly interested in stage and the number of involved digits, but also gender, age, duration of symptoms, tobacco use, rheumatoid arthritis, carpal tunnel syndrome. Diabetes, of course, has been strongly associated with trigger finger, so we were very interested to see if that had any impact on response to steroid injection. Each affected digit received an injection of 4 milligrams of dexamethasone with 0.5 cc's of lidocaine without epinephrine, and then these were reevaluated at 1 month to determine efficacy. Complete resolution of symptoms was deemed a successful treatment. That means they had to be free of locking, popping, clicking, and pain. Outcomes were then stratified based on baseline characteristics and stage of triggering. A power analysis was performed, and we determined that we would need about 104 digits for sufficient power. However, our goal was set at 120 digits to account for about 10 to 15% dropout rate, which we did not experience. But before that total could be reached, unfortunately, dexamethasone became unavailable. So we had to kind of make a tough decision at that time. We had 99 digits and 69 patients. We elected to cease enrollment rather than introduce a different medication that would potentially add confounders to our study. The number of fingers that were involved were analyzed as both independent and dependent variables in order to account for the potential dependency of multiple affected digits on a single individual. We had a total of 69 total subjects. Most were female, consistent with past studies. Multiple fingers, 26 patients exhibited multiple affected digits, 11 abused tobacco, and 13 patients were diabetic. As I mentioned, we had 99 digits included in the study. We met our goal on almost all the stages, except we did have a low number of stage 4 digits in our data. Despite that, there was a significant inverse relationship between stage and complete resolution of symptoms. And there seemed to be a break in the data between stage 2 and stage 3 trigger fingers. So we further analyzed those two groups, breaking the population or the cohort into low stage and high stage triggering. And what we found was a significant decrease in resolution of symptoms in the high stage group, roughly just over 50% resolution versus over 80% for the low stage individuals. Digits, and so this was an important finding. We also looked at multiple affected digits, and we found a 5.8 times greater likelihood of having persistent symptoms following a single steroid injection. And again, this was at 1 month follow-up. Multivariate analysis, looking at the other factors did not reveal any correlation with response to injections. Surprisingly, diabetics and those with a history of carpal tunnel syndrome did not have an impact on response to the single injection. So in conclusion, low-stage trigger fingers can be reasonably treated with steroid injection. However, high-stage triggering or multiple involved digits, surgery may be considered as the first step due to low success rate of the steroid injection, and our study did not show an association between other comorbidities and treatment outcome at 1 month. Thank you.
Discussant for this paper is Dr. Chen.
Thank you for that paper and for taking a look at outcomes. Did have a few questions for you regarding centered around methodology and conclusions. It's unfortunate that you kind of ran out of dexamethasone off the market before you were able to complete the numbers you wanted. But you know, I was curious how you defined poorly controlled diabetes, because other studies have shown diabetes could be a factor, and if you're excluding those, could that affect your results? And with multiple digits, are you calculating resolution by the patient or by the digit? Because you did find that, you know, the resolution was pretty low, but if you have multiple digits, do you need to have all the digits resolved in order to get that credited to you? And is 1 month follow-up really long enough? Because we do know that sometimes your symptoms can return after a few months, and is that really a fair assessment? Because, you know, how many people might need more than one, and could they still be treated with injections and not eventually need the surgery? Now, finally, in terms of conclusions, I was curious as to how maybe this could change your practice or not, especially in light of some of the cost-effectiveness studies that show maybe 2 injections before surgery might be relevant, and putting this just in the context of some of the long-term outcome studies that have come out about success in trigger finger injection. Because, you know, some of them, you know, 40-50% chance of cure, you know, even if that's low, even with your own numbers, you found half of the higher stage. You can avoid surgery half the time. Why not try it?
Sure, those are great points and great questions. With regards to the question about diabetes, our criteria was if they had documented blood sugar over 250 in the last month, or if they had patients stated that their blood sugars had been poorly controlled or over that cutoff, then we kind of left it up to the surgeon kind of have final say, but that was sort of deemed as the threshold for inclusion or exclusion, and was sort of the definition in our mind for poorly controlled diabetes. So certainly that can have an impact on our results, because those patients that were included, maybe their diabetes was well enough controlled that it just wasn't evident in our outcomes. As far as there being the multiple digits, the variables were evaluated. We worked very closely with our biostatistics team, and they actually played an integral role in this study. And they looked at variables both as independent and dependent. And for the purposes of multiple fingers, they ran a number of studies or analyses, in particular what they call a GEE analysis, which is generalized estimating equation, which is a model that allows you to basically assess the association between multiple variables and outcomes while taking into account the dependent nature of multiple digits per patient. So it actually gets pretty complex, but essentially they were able to account for individual fingers, but also take into account the dependent nature of those digits on a single individual. And so that was very important to account for. They actually studied, as I mentioned, both as independent and dependent variables. And another important finding, I think, is that they did find a significant association between multiple fingers on a single individual. And I think that has significant implications for future studies. You can't really consider each individual finger as a separate entity for the purposes of statistical analysis. And that's something certainly that, to consider in the future. 1 month follow-up certainly is not a long time. We actually have followed patients. In fact, we've recently completed follow-up data up through 9 months, and on a lot of patients we have up to 1 year now. And so that I hope to we'll hope to have some more definitive numbers and outcomes as a result of the follow-up data that we have. But that's currently being analyzed and is not, I don't have those numbers today. There does seem to be a trend towards persistent symptoms. If they didn't respond with the first injection, most patients don't respond with a second injection. That's just my own take on the data from what I've seen, but I don't have any definitive numbers to support that today. But certainly we're looking at that because 1 month, is a short amount of time, and there's a lot of data out there to suggest that, longer follow-up may be necessary. The goal of this study was really to help define kind of a cutoff and to help improve our conversation with patients and give them information on the likelihood of response to treatment. And so, if they don't respond initially to injection, I think that's an important thing to at least be able to educate our patients on and give them a little bit more insight into what to expect. As opposed to changing practice, I think it doesn't, I don't think it's necessarily, you bring up a good point, a 50% reduction or 50% rate of success is actually not terribly low, and some patients may say it's worth the coin flip and go with the injection as opposed to surgery. There may be some patients, though, they present with multiple affected fingers, high stage triggering, and for those patients, it's a reasonable thing to mention that, hey, your likelihood of success with an injection or a series of injections may be low, and so here's something you should consider. I don't think it necessarily precludes injection as a reasonable first option, but it's something that I think just adds to the conversation and provides at least some supportive data to bolster that decision and that overall conversation.
A quick question is, how many different providers did the injections? And I know in my hand clinic we have physician extenders, nurse practitioners, medical students, interns, everybody's doing trigger injections. So how did you account for that?
So there were 2 staff surgeons involved in the study. So they were responsible for staging and diagnosis. As far as steroid injection, I'd say most of the time it was the staff surgeon, but we also have a number of residents, myself included, who participated in that under supervision. So there was supervision and guidance to kind of hopefully standardize the technique and reduce the error there.
Well, thank you very much.
Thank you.
Our final presentation for this section will be diagnostic testing requested before surgical evaluation for carpal tunnel syndrome by Dr. Sears.
Thank you to the Association for the opportunity to present our work today. Carpal tunnel syndrome is a clinical diagnosis for which no reference standard diagnostic test exists. And the value of electrodiagnostic studies have been debated in the literature, particularly in patients with classic symptoms where the probability of the test results impacting the decision to pursue surgery may be low, and the potential added costs, delay to surgery, and the fact that electrodiagnostic studies are rather uniformly viewed as unpleasant by patients. Furthermore, the American Academy of Orthopedic Surgery updated clinical practice guidelines for carpal tunnel syndrome published last year removed the recommendation that electrodiagnostic studies be performed in patients being considered for surgery. Instead, now they recommend that either electrodiagnostic studies or clinical diagnostic questionnaires, so using history and exam findings, could be used to aid the diagnosis of carpal tunnel syndrome. Given these changing guidelines, it's unclear the manner that electrodiagnostic studies are used relative to seeing a surgeon for an initial consultation, perhaps whether or not they're being used before even evaluating the patient, or whether the tests are being reserved for cases where the diagnosis is unclear. For this reason, we sought to determine how often surgeons who perform carpal tunnel release in the state of Michigan require diagnostic testing prior to an initial consultation, with the surgeon, and secondarily, the influence of provider and practice characteristics on the requirement for pre-consultation testing. We identified potential surgeons who performed carpal tunnel release in the state of Michigan through online data sources, which included the ASSH member directory, DocSpot, and HealthGrade sites, and recorded provider and practice characteristics from publicly available data, including their profiles and personal websites. And then surgeons were grouped into solo, 2-provider, and group practices based on the number of surgeons within a given practice who perform carpal tunnel release. And from there, we sampled 100 practices to be contacted by phone. And we had 3 trained research assistants who followed a standardized telephone script and posed as potential patients to confirm first whether surgeons performed carpal tunnel release, and also confirm the provider and practice characteristics that were previously recorded, and then ask whether tests were needed prior to scheduling an appointment. Our outcome variable was the specific test, including electrodiagnostic studies or alternate diagnostic studies, including CT scan, MRI, ultrasound, and X-ray that were requested or recommended prior to scheduling an appointment. And we also recorded provider and practice characteristics that included the primary specialty, and we included plastic surgeons, orthopedic surgeons, neurosurgeons, and general surgeons, ASSH membership status, teaching facility status, which we defined as whether they worked with residents or fellows, and then the size within a practice of surgeons who performed carpal tunnel release within that practice. And we designed a multivariable logistic regression model to determine the relationship between those provider and practice characteristics and the requirement or recommendation for testing prior to a consult. So among the 100 practices that we attempted to reach by phone, which included 219 surgeons, we confirmed that 134 of them, or 61%, performed carpal tunnel release. And we found that 57% required a diagnostic test prior to scheduling an appointment, meaning that the caller was requested to have their primary care provider or the surgeon order a test. And 9% recommended a diagnostic test, meaning that the caller was encouraged to get the test and said it would be helpful, but left it up to the prospective patient. And among the 88 physicians who required or recommended a diagnostic test, the majority wanted electrodiagnostic studies, which was not surprising. 22% of them requested an MRI, 13% requested a CT scan, and 9% requested an X-ray. And of note, 22% of them requested multiple studies. And there were 10 unique combination of tests that were requested among the 88 physicians or surgeons who wanted a test prior to the consult. And in looking at provider and practice traits, we found that regardless of the group characteristic, the majority of providers within that group requested or required testing, and that the specialty was the only factor that within the group had a significant difference in the outcome. And in our multivariable regression model, the neurosurgery specialty was the only specialty compared to orthopedic surgeons as a reference standard that had a higher predicted probability or odds of requesting a test, whereas plastic surgeons compared to orthopedic surgeons, although with slightly increased probability, was not significantly different. So in conclusion, the majority of surgeons who treat carpal tunnel syndrome in the state of Michigan requested electrodiagnostic studies before an initial evaluation, which led us to believe that these studies were not being reserved for cases that were clinically uncertain, and that the prevalence of pre-consultation testing was high regardless of provider and practice traits. And CT and MRI were requested by nearly a quarter of surgeons who requested tests, which is against the most recent clinical practice guidelines. And given the debate over the value of electrodiagnostic tests, particularly in patients with classic symptoms for carpal tunnel syndrome based on history and physical alone, many patients may receive tests that do not impact the decision for surgery. And perhaps there is a need to highlight the change in the most recent clinical practice guidelines that has removed the recommendation that patients being considered for surgery routinely have electrodiagnostic studies. In the quest for high-value care, providers should advocate for more judicious use of diagnostic tests. And although we do not know the reason and motivation behind providers requesting tests in this study before the consultation, which could be a variety of reasons, but patients should be included in the decision to obtain tests, particularly when there are reasons that do not directly impact the treatment decision. Thank you.
The discussant for this paper is Dr. Johnson.
Hi, Shane Johnson from Hershey, Pennsylvania. Dr. Sears, I want to congratulate you and your co-authors on your work. I'd also like to thank you for submitting your manuscript to me ahead of time for my review. And I want to just highlight what I found to be the most shocking portion of your results is what I see as a very high amount of ordering for CT, MRI, ultrasound, and X-ray for workup of carpal tunnel syndrome in Michigan. In my own practice in Hershey, the population is somewhat rural, maybe suburban, and the overall litigious activity in our region associated with carpal tunnel syndrome and surgery for carpal tunnel syndrome is relatively low, I would say. And myself and the other hand surgeons at our institution do not uniformly request studies prior to evaluating patients. However, in some other parts of Pennsylvania, such as Philadelphia, which is known for litigious activity, I can tell you that the rate of ordering studies is quite high, in some cases 100%, and that's based on my own experience as a hand fellow there and some of my colleagues there. I was wondering, in your study, do you have any geographic data that goes along with the results that you found in terms of maybe grouping of a higher rate of test ordering in urban environments? And number two, question for you, it's really more of an abstract one, is in the era of cutting costs while improving outcomes, can you propose an education strategy for surgeons that perform carpal tunnel release to minimize the use of indiscriminating studies? Thank you.
Thank you for that, for those comments. I appreciate it. So for the first question, in terms of geographic variation, that was not one of the variables we looked at. However, we did really want to look at the within group variation, particular if you had 3 providers in a practice and we called them on different days to determine if they had a different response between the providers, but whether or not that had any influence on the requested test, because our hypothesis was that likely the office staff were not going to discriminate between the individual providers, even if the individual providers had differences of opinion, just based on what happens in my own clinic. And so we did find, as we wrote in the manuscript, that about half of the group practices had a uniform practice, meaning that either all didn't use the test or all did. So it remains unclear whether or not the office staff really follow individual provider recommendations, or but we did not look at in terms of urban and rural differences in the requirement. And in terms of what we can do from an educational standpoint, I really think it starts with a change in mentality, or particularly within our residents and fellows. I think one simple question that I often ask myself when I'm considering getting a test is whether or not it's going to change my management. And I think ingraining that question and mentality in our young surgeons moving forward is probably one of the most important things we can do. And then from there asking, okay, if I don't get this test, what's going to happen, as a follow-up question.
Brady Howe from Hershey, thank you. And my question is, in Pennsylvania, I'm from Hershey, a lot of carriers, particularly workers' comp, require nerve conduction tests prior to surgery. Do you know if that had any effect, and did you look at that in terms of, and I don't know what the laws are, what the rules are by different carriers in Michigan, but is that a problem there as well?
So for this study in particular, we through our standardized script, we told the office representative that we were paying out of pocket. And so I don't know if just that general habit of requesting electrodiagnostic studies for workman's comp patients gets translated to all patients or not. I think that's a very interesting question for a future study. But for this one in particular, we said we're paying out of pocket. We have a high deductible plan when they asked for insurance information.
Scott Lifshay from Baltimore, Maryland. It seemed like there was a large cohort of general and neurosurgeons doing carpal tunnel release in your study, meaning those who have neither plastic nor orthopedic training, let alone hand training. Do you have any information about how this compares nationally or to other states that may have assessed this that also might have influenced, again, that very large number that you saw in your neurosurgery group?
Right. So I don't know relative to the national cohort, but I suspect, though, that even though amongst all of the providers, they represented I think there were 33 neurosurgeons, but only 2 general surgeons. I have a suspicion, though, that proportionally they're not doing the same number of carpal tunnel release. And that's because in national data where we've tried to look at the use of CT, MRI, ultrasound, although nobody asked for ultrasound in this study, it's really actually not a high representation in terms of all the patients having carpal tunnel that get those studies, which actually is a really good thing. So I don't think, honestly, that even though they represent a large number of providers who are performing carpal tunnel release, I don't think proportionally they're performing carpal tunnel release on the same magnitude that orthopedic surgeons and plastic surgeons are. Just my hunch from indirect data looking at national utilization of those studies.
Thank you.
Hi, Andrew Chen from Connecticut No Disclosures. I was curious if you could share with us the script, because that would just be interesting. And also, I wonder if the comment that paying out of pocket would generate perhaps some of these requests for some of the doctors who maybe had an MRI machine in their office and wanted to profit off of that. And what are your thoughts?
So we have a manuscript under review with Journal of Hand Surgery right now, but if you email me, I can send you the telephone script. I have it as an appendix in our manuscript. And so I do suspect that financial incentive was at play in some cases. We didn't start with this hypothesis in mind. I actually left it open-ended because I suspected most of them were going to ask for EMG, but I was really surprised at the number that asked for CT, MRI, and actually both sometimes, which I thought was a mistake, but it wasn't. But some of them did offer to order the test, which leads me to believe that it's financially motivated. But we didn't start with that question in mind, so we didn't necessarily record the number who offered to record or to order the test.
Any other comments or questions? Okay, thank you very much.
Thank you.